knee pain, and plantar fasciitis. So why don't we start at the top, right? What do you, what's your history or what's your experience treating headaches?
What? Oh, treating headaches. Oh, that's a good goal. Headaches, typically, I actually go more of our traditional training. So I kind of look at like the flow of energy in the body. I do ask questions like whether they're migraine, tension, cluster headaches. You know,
Right.
there are some headaches that are caused by muscular tension, right? Those kind of wrap around, they start at the neck. You know, people will be familiar with those. And so those I'll do like the trigger points, but generally speaking, I'm thinking like, you know, treat excess by below and like harmonizing points and things of that nature. Now, in terms of causes, right, there are different kinds of causes. Some people have postulated blood flow, anomalous neuronal activity and things of that nature. But most of my headaches, to be honest, which actually even before I started working here, was hormonal.
Yeah.
So
I agree. So I guess what you want to do with headaches, because it makes such a difference, is we want to know what type of headache. So number one is the migraine. Everybody thinks they have migraines. Migraines have a pulse to them. They're bounding, and they're stabbing and painful. There's vision loss, there's nausea, and you're right, yes, it is a hormonal experience. We find a lot of women with irregular, uncomfortable, painful cycles get migraines. I think what people get confused between migraines and pain, like really severe headaches, is a cluster headache. Cluster headaches are stabbing behind the eye, above the cheek. Anything below the cheek that's stabbing and painful is a sinus headache. And you can already see where we're going with this, because sinus headaches are treated frontally. Migraines, you don't treat migraines. I don't treat a migraine. Sometimes they make it worse, right? Because part of it is like
definitely not like locally.
No.
I mean, some people will talk about even to you yow.
Yeah.
You know, if you do it with a fine enough serum, you can get away with it. But generally, I stay away from the head because you don't want to aggravate it.
Well, the thing is about prophylaxis. It's like getting rid of, make sure you don't have headaches, like treating ahead of it. So what this becomes is more of a woman's health issue, like regulating the cycle, then there's less incidence of migraines. The other thing with cluster headaches, they come on, they say like clockwork, and they can be very uncomfortable. But the same thing with headaches is you don't want to have a headache. You don't want to treat the headache. You want to make sure that the headaches don't come. So, you know, the thing with frontal sinus pain, if you lean forward and it gets worse, then you know it's a sinus headache. Then you're talking about frontal, the face. But then that gets caught up with the stress headache, right? The band. And what I find, that's neck and upper back. That's like the traps actually pulling on the scalp, putting tension on the forehead, staring at a screen, typing. It's all upper back and neck. And why are we saying this? It's really important to get this down. If you don't want the headaches to come back, you have to get to the root cause. Whether you're going to do channel theory, you're going to do temporal headaches, or you're going to do upper back bladder type headaches, you have to get to the root cause.
Can you talk a bit about the connection between hormones and headaches? Like how exactly, because we'll see periods and menopause, you'll see headaches around those.
I think when you talk about like women's health and headaches or conditions and symptoms, what you're looking at is a vascular event which comes to blood flow.
Right.
So if you're 13, 14, 9, 11, whatever in menarche, and you're not getting your cycle down and it's painful and uncomfortable, you don't go on the pill, right? That's the worst thing you can do to the patient.
And why is that?
Because they're going to want to get pregnant in 15, 20 years and they've been on the pill, and guess what? It doesn't work that way. So figuring out what it is and getting the blood flow right, you can correct the cramps. But I find a lot of women in their reproductive age get migraines, right? Again, a vascular event, because migraines are, what happens is the blood vessels kind of dam up, it backs up, and then the blood flow comes in and flushes, and that's where you get that bounding sensation. And then with women who are going through menopause, you know, they'll get hot flashes in the chest, but it all comes down to the way the blood flow works. And if there's stagnation, what we call in Chinese medicine, the blood flow is not flowing properly, you're going to have these hot flashes, headaches, and cramps. But what's important again is getting to the root cause and preventing it so it doesn't come back.
Absolutely.
But since we're talking about pain, we might as well move on to neck. Right? Neck is interesting. Those neck pains, you can have pain in the neck. You can also have pain in your upper shoulder. You can have pain between the shoulder blades. But there's like that one point that we talk about all the time, Sanjiao 15. It's like the pinpoint, the linchpin. No matter where the headache is, where it starts and finishes, that point gets right to it. And it's important to get the local twitch response to get those muscles to take pressure off. And that's good for those frontal type headaches.
And then that can be both tricky and fascinating and tricky because there's so many different muscles that run over the neck attaching at different points, right? You have the spinous cervicis, spinous capitis, right? You have the different layers like platysma. You have the small muscles of like the rectus capitis, right? Because like I've even heard like most people don't know, but there's actually underneath like the big muscles, like the trap that people know of, like spinous capitis. There's actually some like small muscles like right at the base of the occiput. And actually, I was actually spending time with a friend of mine. She has some headaches, and then she doesn't live too far from me to treat them. But she was actually saying that somebody actually triggered that small muscle that's like very like not many people would think like that's the muscle. Most people don't know it's there, and it relieved it. And so it's like the neck is such a fascinating web of different muscular relationships that sometimes you need somebody with a lot of experience like yourself to be able to sift through all those different layers of muscles that sit on top of each other. Right. Like I suggest if anybody's truly fascinated to actually go on Google and look at like neck anatomy or back anatomy and like look and ask for cut, because you'll see like on one layer you see like what you would see on one, and then they have to cut it away to see underneath. So going through all those layers and being able to decide, okay, you have levator scapular attaching to the head, you have spinous capitis attaching, and so to be able to discern that and then be able to put the needles in the right place to get headache relief as often as you do with the booklet and tune-up. Like, you talk about like all the different places that
so I think the points, and they're pretty comprehensive about where to treat. So if you're doing GB20, which is the base of the skull, you're doing UB13, which is in between the spine and the upper border of the scapula, or SI19 or St. 15, it's almost like the body already knows. Like hitting those points and the way they react to it will determine. I think the like you said, there's so many muscles and you can get caught up in treating it. I think one of the most important things is if you're in today's society, if you're staring at your phone for 6 hours or scrolling 6 miles a day, this is what all the digital marketing wizards are telling me. People are scrolling on their phone 6 miles a day, and then the typing. What you're doing is you're overusing those neck muscles. So what you are allowed to do, according to our illustrious occupational safety and hazard and government nonsense, you're allowed to take a break. You're allowed to stop and stretch. I think if you want to prevent a lot of this discomfort in the neck, yes, you could treat it with acupuncture, but what is the end game? Do we just continue treating with acupuncture? No, we want you at some point to be kind of free of it. So whether it's one of those smaller muscles or the trap or whatever, what we want to do is make sure that you're not abusing the neck. Right? Stop and take a break, stretch. We like chin to chest here. That's a really popular one. But again, we add that sort of like flared elbow to kind of like those long neck and back muscles are very difficult to stretch. So we want to hold it longer and we want to breathe into it and handle it slowly over time, so that when you're staring at the desk or you're at the computer or at your phone, we're kind of undoing all the damage that you're doing throughout the day. And that's where we make those breakthroughs, like between the acupuncture and stretching. That's where the problems go away. The headaches go away because we're getting to the root cause.
Yeah, absolutely. And I think you highlight something great about like that kind of alteration between being aggressive, like getting that twitch response, then also alternating that with those slow movements and slow stretches to kind of gently get the muscle into position. That's like
you want to be careful too when you're treating a patient because it's so close to the head. It's vulnerable. With the twitch response, you want to take a very light and subtle approach. Whereas on the upper back, it's okay. You can go to town all day, and the bigger the jumps and the bigger the muscle releases are, the better the patient is. And then you got your upper back and neck. I see them both as like the same problem. But it's obviously the traps. But it can go anywhere depending on which muscle's tight. So with that being said, go ahead.
Well, I just wanted to pop in because you mentioned something about not going too hard. Like that's one thing that I've noticed is like especially being a jiu-jitsu athlete, like people like to go hard on those Theraguns.
Like, that's the worst.
Yeah, exactly. And so
if you have a Theragun, it's in the manual. 30 seconds, no more. Move on and use the broad head. When you use those like narrow, accurate heads, you're really just beating the crap out of them. So you're doing the opposite of what the Theragun's supposed to do. But I know that because I learned the hard way. So 30 seconds.
And here's a fun tip. I actually saw some research recently that says that actually you can recreate the Theragun feeling by actually just stimulating the tendons for 30 seconds.
That's great, but when somebody's scrolling 6 miles on their phone, they're not going to have time to
but they have time for the Theragun. That's what I'm saying. So,
fair enough.
But that commitment, right? Like you said, because like I see you do that. Like anybody who does a Theragun, you're always telling like don't dig in there, right? And same thing with the aura ring, right? Like when people get super stressed tracking their period, like
you don't need to know about the quality of your sleep.
Right.
It's either good or not. You know. Your phone shouldn't tell you how good your sleep is. So neither should a Theragun determine the quality of your muscle health.
So I'm highlighting that because, you know, having fairly recently graduated and going through, like, not everybody is, you know, so committed to making sure the patients have a good experience. Like, some people are like, no pain, no gain, right?
Right.
But, like, you know, especially, I don't know if we can talk about
we're
it.
all gung ho and we're motivated. We
Yeah.
wanna get results, and
Yeah.
sometimes you go a little fast. Especially, I know it's a culture thing. I know that most teachers from mainland China were like, if you're not hurting the patient, they think you're not doing a good job. Where if you're in a consumer-based market in the United States, like, if you hurt somebody, they're gonna run away screaming. So it's not to say that either one or is effective. It's about finding what the patient needs and what they got. I think once they realize that they can get better and we communicate the experience, then they're motivated to get better through a slight bit, but generally not uncomfortable.
Well, you figured a way to just get rid of that problem entirely. Would you like to tell them? Like, how you have...
You're gonna have to remind me.
What? You know, see, he likes to play tricks on us guys. But the laser, right?
Oh,
now you can go ahead.
now you pulled the test what I mean. Yes, the laser is even minimally less invasive than acupuncture. So if acupuncture is minimally invasive, laser is non-invasive. So laser is a really great way, because what laser is really good at is simulating the local and the central effects. It's really good at releasing endorphins. It's calming, and it is really great at stimulating local tissue flow. So if we were to say, what's a common thing we treat here? Low back pain. That's really fantastic. Treating low back pain. When you get to the QL muscles and stuff like that, or quadratus lumborum, or the vertical muscles on the spine, you still have to do the manual acupuncture, and that's where we say, like, it's not just enough to do acupuncture well, you have to do it better. So implementing technology is one way. Everybody knows technology makes your life better. So if I were to say I could get you better in 6 to 12 visits with acupuncture, we can cut that time down with a laser.
Absolutely.
Right? Because it's just one more added effect.
And with less pain. Like, no more, because we know acupuncture doesn't hurt, but some people are sensitive, or people might feel something.
Yes, the imaginary pain that everybody thinks.
Yeah,
we have a patient in the clinic who tears the walls down every time she would. Granted, she's a young kid, but she got caught up in the whole thing. What your pediatrician does is stab you with a needle, and that's stored in your brain. That's there. So when you say needle, it freaks the patient out. So we have to take an extra 15 minutes just to get her to see the fact that she's the effort and the emotion that she's putting into, like, not wanting to get the treatment is worse than the actual treatment itself.
Absolutely.
So whether you like or don't like needles, we don't have to call them that. We call them filaments. The mental aspect of working yourself up towards it is 100 times worse than what it actually is.
Yeah. But, you know, that takes a very mature, like, seasoned outlook to get to that point. The laser, you don't have that. You don't need that spiritual development. You can just slap it on there, right?
Yeah.
So that's convenient.
What's best for the patient is definitely a combination of all things.
Absolutely.
The other thing we like to do here is sciatica, right? 99% certainty, 20 years of experience. If I know one thing after 20 years, is that sciatica is an easy fix. If you have that butt pain that's traveling down your leg or the front, the back side, doesn't matter, this is where you want to come. Get checked out, go to your doctor, make sure it's nothing worse, but definitely make an appointment to see this, because you could waste months at physical therapy and not get better. You could do pain management intervention and it'll block the pain but not get rid of the root cause, it'll come back. But we are very good, and this is just something to say about the medicine itself, not my ability or Greg's ability. This is tent show revival type stuff. People come in with walkers, people come in with canes, people come in with wheelchairs, and after a few visits, they get rid of it. I see a patient with a cane, I'm like, let's get rid of the cane. Let's do it, let's get rid of it. It's just that simple. When the butt muscles from sitting at a desk all day long, they call it dead butt, by the way, you can look that one up. The muscles get tired, they clamp down the sciatic nerve, and it wreaks havoc.
Yeah.
And when we treat it, what we find is that it's either gonna get better on the way up to the root source, or it's going to split and get better, and then what you're left with is, like, then you have actual pain in the leg. It could be the quad, it could be the hip, the calf, and that needs to be treated separately. But overall, this is a very high success rate. If you have that problem, call us now, make an appointment, open up our Instagram, But do yourself a favor and just don't suffer anymore, and give us a call.
But Doc, what about that picture they got from the chiropractor or doctor that says they have a herniated disc?
So I don't care what your back looks like. You can have all the herniations in the world. As a matter of fact, I have herniations, but I don't have back pain. And that comes to the second aspect of, like, after we treat it, we do give them a course of seated pigeon. You're sitting anyway, right? You're sitting watching this. If you have sciatica, do a seated pigeon pose, right? It's that simple. You have to loosen up the muscles. They cannot be, literally, you're sitting on your ass all day long. You're cutting off the blood flow. We talked about stagnation. We talked about circulation. If you have a problem from sitting, the worst thing to do is sit more or try to implement something to kind of work yourself out of it. I mean, we'll get you there faster, but the stretching is a big piece. And one of the things about stretching is once a patient catches on and realizes that they don't have to be in pain anymore, they have to internalize. You can't talk to people like, you have to stretch, you have to do yoga. No, nonsense. They have to experience the relief and know that. One of the incentives why we tell people to stretch between visits is that you maintain the relief you get here. And again, this is a therapy medicine. It's going to take a couple visits to go away, but let's not take one step forward, 2 steps back. Let's keep forward momentum, and that's what the stretching comes in. It incentivizes the relief and keep the relief. And when people actually experience the relief, that's where it really clicks. That has to happen in here, not in here in their head.
Yeah, it's not like finger wagging.
Yes,
it's like
that's like the worst. It's dismissive, and people kind of sick of it and fed up with it. They don't want that.
And they don't need that. They're grown adults, right? We're supposed to be here to help and guide them into relief, not sit there. And,
you do need to present the information
right.
in a preachy, didactic, talking at kind of way, and then the patient has to experience it. And once they experience it, it's like the light bulb, man. It's like the greatest thing. When you come to it, that's the reward in itself.
Now, I've noticed something about your approach that I don't see often. You really like to dig in. Like whenever a patient has like an anomalous event, like say, it's a little bit, like you really like to dig in, which is a vastly different experience than they're used to, right? Like typically when you go to the doctor, put in a waiting room, you ask for like a list of questions, but you like to
the 10 questions. That's the 10 questions. It's in our medicine, it's an interview.
Yeah, but
it's actually more of an investigation.
Right.
Right, what are you looking? You're looking for clues for the roots of. So we talked about headaches, right? And we said to the patient, you have a headache, that's great. You have a migraine, you don't have a migraine. They don't end up having a migraine because it's not bounding, it's not stabbing, it's something else. But if you don't ask those questions about their cycle, if you don't ask those questions about all the extraneous stuff, then you don't get to the root cause of it. You find out it's probably a stress headache or even like a cluster headache. But again, it's very important. It's a critical part, and what differentiates our medicine from everything else is like we are having a conversation. And listen, you don't have to get it on the first visit. We're going to see each other a few times. So if you could say, hey, by the way, I just realized I do this all day long, and then that's a piece of the puzzle, but you're not going to know unless you ask it. You have to ask over and over again.
Right.
But it's not that. That's what separates us. When you form the pattern, right, and you get to the diagnosis, you get to the root cause, and you can be more effective in your treatment. I could throw a few film into your lower back and walk away and say, okay, that's great, but if you don't get better, I didn't ask the questions about, is it referred, is it the back, is it from something else, is it high or is it lower? These are all the things that are really important about talking to and not at a patient.
Just real quick before we move on to plantar fasciitis and neuropathy. When you're investigating, would you like to tell them about weather? Because oftentimes, it has something to do with their weather, right?
Okay, so every so often when you get a new patient who's not, they'll get a little bit better, and then the weather switches, and then they're miserable. But it's not them, it's every other patient that we treated after that is going to have a bad day. I can't sell you on a new body, right? Sometimes you got to blame it on the rain and old bones, but what I can assure you is that as you get better, those days are less worse. They're easier to get to. It's 1-2 visits, not 12 or 6 to get to where we need to be. But I know when I hear patients complaining, they'll all complain. Or they'll have something with allergies. Or it's like an epidemic. Everybody's sick. You lose a couple patients on the schedule, and then 5 more fall off because they're in school or they have kids. Same thing with back pain. Everybody in that weather, that damp cold. Listen, we live in the worst place. Northeast, cold, rain, damp. That's what the Brooklyn tune-up really was devised. It's for people who are out there beating their bodies, construction, firemen, police officers, gun belt syndromes, people, and then the weather, the cold, the damp, which everything is just angry, everything is tight, the weather is miserable, the people are miserable, their bodies are miserable. What can we do? We can implement, and that's where you're saying the weather does make a factor.
Yeah, absolutely. Plantar fasciitis, neuropathy?
Plantar fasciitis is not foot pain. Plantar fasciitis is calf pain. What I've seen treating the foot and not getting, and I've had to beat my head up against the wall with this, is like treating the foot for plantar fasciitis. Yes, you treat the foot, but if it doesn't get better, what you're looking at is higher up. What it is all the muscles from the calf run through the foot, through tendons and the Achilles tendon, and the calf gets tight and tends to pull. It pulls underneath. And we've kind of found a couple extra points off the meridian that aren't extra points that seem to be effective. But it is like, a calf thing. You got to stretch the calves to get to the plantar fasciitis for sure. That's the one thing I could say after treating it ineffectively for maybe 10, 15 years. And I've confirmed this with other fit doctors. They'll say the same thing.
No, absolutely. I can attest for that personally, because I know that there's a couple of things that when I first got out of school that I was a little dodgy on. I just didn't, you get a whole smattering of things. Everybody has their
Yeah.
techniques, and you focus on some things. Plantar fasciitis is like, you know, you try like the bladder 60, like, you know, the TCM, and you
Yeah.
get some relief, but you know,
Yeah.
you want to do better.
Mhm.
But then once I started like implementing what you were talking about,
Right.
I've gotten like a lot better results.
Yeah.
So I know that beating it against the
The
wall.
thing that's gonna make a difference with foot pain is shoes. And ladies, you're gonna have to give up the high heels and the fancy footwear if you don't wanna have foot pain. And I know it's a tough
Right.
one, it's a hard sell, but trust me, you know,
It's a real hard
those
sell.
Hokas are popular for a reason. Those are like marathon, ultra marathon running shoes, and they're very cushiony, so, you know, think about it. Every time you take a step, you multiply your body weight times 3. That's just walking. So, if you don't have the right shoe and you're crashing on your foot all the time, you're gonna have foot pain, so.
I don't know, Doc, you're telling them to sacrifice all those beautiful outfits?
You know, you can wear it for a couple hours if you want to go out on a night on the town,
Yeah.
but not all the time.
And listen, you can look good, and then if you feel bad, call us,
They
right?
make them very nice. They make beautiful colors. They're gaudy, big, like, it's kind of like those old orthopedic shoes. They kind of rebranded them, and they're popular now.
I don't think you're selling it to them, right?
Yeah. Hey, this is about pain, it's not about fashion.
Last one is
Neuropathy.
neuropathy.
So neuropathy pain scale is, and this is again based off of interviewing patients over the years, it's walking on, it's so funny because multiple people say it's like walking on cardboard, like mushy
Yeah.
cardboard.
I've heard cardboard,
Yeah.
broken glass.
Yes, so brass knuckles,
Yeah.
fire and glass, like
Yeah.
glass and fire.
Yeah.
It's like extreme cases, and it's usually for patients who have been through post chemo treatments. A lot of that post
Diabetics.
chemo,
Long-term diabetics, I've seen.
some, the majority though in this clinic, in this practice, have been post chemo treatment and then just like
Well,
wear and tear.
That's where probably demographics going,
Mhm.
because I feel like people here would have their diabetes under
Yeah.
control. But I was treating somewhere else, and their
Yeah,
diabetes.
you get a
were-
lot of diabetic
No,
neuropathy.
no,
Yeah,
no.
that's like that sludgy, backed up. That's stagnation right there.
Yeah.
No blood flow. Yeah, a neuropathy very effective. The truth is, it's going to be difficult. It's going to be tough. Nerves are highly complex structures. They need a lot of but we can follow up with that some other time down the road. That's a conversation. That's more neurological, less muscular.
Yeah, and that's like, long-term trying to revascularize the nerves that have been dejected. So it's effective, it just takes longer because the nerves have been so chronically deprived of blood flow.
Well,
that
what is
we
a
start
nerve?
to-
A nerve is actually a conglomeration of like 4 or 5 differentiated cells. Other than the dendrite, you got astrocytes, gliocytes, all that stuff. Like each one of those is a living structure. That's why it's hard to come back from a nerve, like spinal cord injury, because it's complicated. It's not impossible, but it does get better. It takes some time, but like you said, you have to revitalize those nerves. And one of the things like, oh, I'm numb. Then we get pins and needles. Pins and needles, like when you get the blood flow back, so that's a good sign. When the pain starts to go away. So I think we're gonna call it today, and then we'll follow up next week. We'll go into women's health. But thank you for those people who participated in the survey.
Thank you. Take care. Have a good one.
How long did that go?
It's 3:03.